I welcome you all in today's CGR. Today's topic is glomerular disease, its burden, pattern, outcome, challenges, and future perspective. As we know, chronic kidney disease have a great impact on healthcare, and it is one of the disease that have significantly affecting health budget and overall quality of the life. There is a different stages on which CKD is divided, and that is on the basis of GFR and albumin excretion. It has an impact on mortality by causing hypertension, and then hypertension lead to the cardiovascular mortality, and there is a direct impact of kidney disease on the heart through disorder of mineral and bone metabolism, metabolic acidosis. It is also induce inflammation, have an electrolyte disturbances, and anemia are indirectly affecting the overall mortality. So there is a direct and indirect effect of mortality because of chronic kidney disease. If we look overall prevalence of CKD, there is a global prevalence of 9.1% is there. That was estimated globally in 2017, and it is continuously increasing with time because the risk factor for CKD is diabetes and hypertension, and diabetes is one of the common disease that is its prevalence is increasing day by day, and especially developing countries like India where the burden of diabetes is very high. So India in future the burden of CKD is likely to increase. There are other countries also where the prevalence of CKD is out of proportion, and these countries are as highlighted in this graph. So most of these countries are located near the equator. So these are the countries which are located near the equator. This is Mexico, Panama around, and these are the area where the equator is passing. So this have some tropical impact on the prevalence of CKD also. If we look from the Indian perspective point of view, what the prevalence in India is there. So on the basis of population studies and all study base, the prevalence of CKD is around 12.1% to 16.7%. And if we look the advanced stages of CKD, in advanced kidney failure, stage 4 and 5, the prevalence is around 1.9 to 2%. So this advanced CKD is likely to going to impact on healthcare system immediately, like they need renal replacement therapy and immediate healthcare requirement is there. So both CKD and the advanced CKD is likely to increase in India in future. So what are the pattern of chronic kidney disease? This is one of the largest study from India published in CKJ, and they found that this study from the PGI, and they found that diabetes is the most common cause of CKD, followed by CTIN or CKD of unknown origin of around 19.5%. This is the diabetes that is causing 25% in females, and the males around 24%, overall 24.9. That is CTIN, that is 24 or 22.8, and overall is 23.2. CGN, chronic glomerular disease, that is the topic of interest of today's presentation, and this is around 14.7%. Rest other are hypertensive and polycystic kidney disease. These are other causation of CKD. So CGN is causing around 14.7% as a cause of CKD. So how it CGN involved? CGN means chronic glomerulonephritis. Chronic means the disease had set in advanced form and the functional status of glomerulus is lost. So kidney consists of nephrons, as we all know. Nephron is a functional unit of kidney. And in nephron, glomerulus is a very important part of the nephron, and that has an important function of filtrations. And this consists of various compartments There is a mesangial compartment is there. There is a capillary. This is a mesangial compartment. This is a capillary loop, and this is a glomerular. This one, periglomerular space is there where the filtration occur. If anything happen from the vessels, if there is any inflammation, any deposition, so the integrity of the glomerulus affected and it cause glomerular damage, and that we defined as glomerulopathy or glomerulonephritis. These are the primary glomerular nephritis that we often see. These are the focal segmental glomerulosclerosis, membranoproliferative, minimal chain disease, membranous nephropathy, and diffuse membranoproliferative glomerulonephritis, IG nephropathy. These primary glomerular nephritis we call when the origin, especially kidneys are affected. We don't know what is the cause. Most of the time we don't know what is the cause of that, but there is inflammation that is causing damage inside the kidney. There can be a secondary glomerulonephritis. The common are lupus nephritis, anoxylon purpura, post-infectious amyloidosis, hypertensive nephrosclerosis, post-immune that manifests as a crescentic GN, and other are diabetic nephropathy. These are called secondary because there is a systemic disease is going on and kidneys are involved as one of the another organ that disease is affecting. So if we look what is the burden of glomerular disease in our department, there are three ways we get the references of glomerular diseases. One is inpatient. If we look, there are ICU and emergency references. And from ICU and emergency, most of the time, these are the condition where vasculitis or pulmonary renal syndrome is there. They land up in the emergency and they require ICU care. So that consists around 3.5 to 5% of glomerular disease burden. If we look from the reference point of view, that is coming mostly from the ward, and out of all the references, around 33.3% references consist of glomerular disease. This is 33% overall references of glomerular disease, and out of these 33, highest references from the medicine department, that is considered around 82.35%. Rest are in pulmonary medicine, obs and gynae, especially postpartum AKI that can manifest in the form of a flare-up of the glomerular disease and other glomerular disease. And this is a dermatology when the skin is involved as a part of systemic disease. These are the different departments from where we get the references, and major chunk is coming from OPD. Let's see what are the the pattern of glomerular disease from the OPD. So this is as you know, we are all daily seeing this crowd when we are passing through the counter. Randomly we selected one day. Wednesday we took as a day from which we collected all the patients' data, and we found that it is around 182 patients of CKD, and we try to find what are the pattern of disease is going on in these patients. So if we see, there is no big difference in the CKD patients. The mean age is around, male is around 50, and it is nearly equal in female also. And if we see the cause of CKD, diabetes, hypertension, CGN, CTIN, CKD of unknown origin, genetic cause, and diabetes have and hypertension have at high age of presentation, and CGN presenting at young age. Out of all the CKD causes, CGN presenting in young patient, so especially it is targeting young population. If we look further into that and we try to dissect it further on the basis of gender, so again there is at high age the diabetes and hypertension are presenting. In the chronic glomerular nephritis, again both male and female there is no big difference, and both are present at young age, and rest of the cause are slightly on higher age. And if we look on the cause of CKD, this is highest is diabetes. Diabetes is around 27.5%. That is nearly equal to the what is the overall diabetes burden in India. Because the last study, that is here also the prevalence of diabetes around 30%. So we are also 27.5%. CGN is 16.5%. That is, we are matching with the overall Indian population, or Indian data. CTIN is again this one second most common cause of CKD. Rest as CKDU is around 9.3, genetic cause 5.5. And out of these, this is the highest is diabetes, CTIN, then hypertension and CGN. CGN is the fourth cause of CKD in our database. So, if we look the overall kidney biopsies done in AIMS, because most of the glomerular disease are coming from the kidney biopsies, and if there is a continuous increase in the kidney biopsy number, we started in 2016, and after that there is in 2016 around 10, in 2017 there is again continuous increasing. So this is the histogram that is showing there is a continuous increase in the number of kidney biopsy we are doing in our department. This is the time when there is a dip because of COVID, but again there is an increase in the kidney biopsy number. And if we see the pattern of glomerular disease, most common cause is primary glomerular disease. Primary glomerular disease consists of 50.3, second is 34.2, and rest other like CTIN, ATN, and these are around 15.5%. So primary glomerular disease is the most common cause of glomerular disease pattern in our center. And if we look further, there is what are type of primary disease, glomerular disease is there. So this is the MCD, FSGS that is shown in the graph, MCD, FSGS, membranous nephropathy, IgA nephropathy, and MPGN. Out of this focal segmented glomerular sclerosis is the highest number. These are the patient of secondary glomerular disease or other than secondary like ATN or AIN. So in primary glomerular disease, FSGS is the most common cause of primary glomerular disease. And this is absolute percentage that here is showing. Now we further dissect this primary glomerular disease, and we found that there is a slight change in the age prevalence with the primary glomerular disease, and MCD is present at young age. The mean is around 20 years. FSGS is slightly on higher side and equal in both male and female, and membranous is slightly on more higher side, more than 40 years. And after that, IgA nephropathy and MPGN. So this is a typical pattern of primary glomerular disease here in our center with gender differences. What important thing I want to highlight here is that there is a slight change in the pattern. If we look the data from 2016 to 2023, MCD age is continuously increasing with years. So if we look in 2016 or 2017, the mean age of presentation of MCD was at lower age, but as year passes in 2023, the age of MCD presentation is slightly over 25 mean age. This is one difference. Other is FSGS. There is a U-turn pattern of glomerular disease. There is it around 40 years, then it decrease further. And in around 2019 and 2020, it is further decrease around less than 20 years. And again, it is normalizing to the same age, FSGS. Third is membranous nephropathy. There is no big difference overall. In every age, these bars are showing years, the 2016, and according to that, and all data are represented here. So there is no big difference of membranous nephropathy. And here again, there is no big change in IgA nephropathy, but there is a significant shift in age in MPGN, and that is continuously increasing. That need to look why there is so much change with the year in this age group, this disease, and there is a change in this disease, FSGS, and why there is change in MCD. Yes, that need to look. So we took MCD and we found that this is a continuously increasing in age, and there is a plateau. There is no big change now here. So when we find the data and we go into the data and we found that the pediatric representation is continuously decreasing in our database. Earlier, the pediatric kidney biopsies was more representations, and as a year passes, the pediatric database is slightly decreased in our database. So that might be representing this shift in the age from younger age to around 25. So shifting towards the adult presentation of MCD. So this might be a bias in the form of representation of data. Another important is the FSGS, why the FSGS is taking U-turn. So we find that at this time, this is the time of COVID, 2019, and 2019 have the youngest presentations overall mean of the FSGS. And data shows that FSGS is one of the glomerular disease that is contributed by COVID. So both collapsing GN and non-collapsing FSGS are one of the forefront cause of COVID infections. So this might be because of COVID infection that predispose or shifting this FSGS in young age. Second is MPGN. Why there is a continuous shift in the age as now it is at around 60 years or around 40 to 60 years the MPGN, mean presentation of MPGN is there. So further we dissect the cause of MPGN. One is C3 dominant and another is immune complex mediated MPGN. And we found that around 2019 there is an increase in the C3 dominant MPGN is there. And after that there is an increase in the immune complex mediated MPGN. So this is a very interesting finding. And we found that there is, when COVID infection is there, it affects the complement activations. So COVID infection can lead to the activation, and if it is uncontrolled or dysregulated, these patients at high risk for organ damage. So might be this slight increase in the post-COVID time of C3 dominant might be contributed by the COVID infection. And why there is a increase in the immune complexes MPGN after COVID, and this is the data where people found that autoantibodies after the COVID infection increases. Both ANA and other autoimmune disease increases after COVID infection. So autoimmunity might be increased by the COVID infection, then lead to the antibody-mediated MPGN. This is one very interesting study. But again, the issue is not solved here. The MPGN is continuously increasing in elderly patients. So why there is so much increase in the elderly patients? This is one of the very good study. They found overall autoantibodies form in patients who got COVID infections, and they dissect it according to the age. So those who are less than 50 years and those who are more than 50 years. And this is the more severe autoantibodies in different bar graph. So they found that those who are more than 50 years have a more strong autoantibodies, most of the autoantibodies. This again shows that with aging, if the patient get COVID infection, the risk of autoimmune formations and autoimmune disease increases. So that can explain, might be the increase in the prevalence of MPGN from young to elderly after post-COVID time. So if we look the secondary causes of glomerular disease, again the secondary cause is around 34.2%. And in the secondary causes of glomerular disease, lupus nephritis, amyloidosis, diabetic nephropathy, these are also highlighted here, and renal cortical necrosis, crescentic GNs. And out of this, lupus nephritis is the most common cause of secondary glomerular disease. And if we look for the absolute data, it is in secondary glomerular disease, it is the highest, around 36.7, and followed by crescentic GN and amyloidosis. Now we further like to look the according to the gender. So there is a lupus is present in young patient, both male and female. There is a young age presentation of lupus, and amyloidosis is slightly on higher age, more than around 45 or 50. Diabetes is again have a variation of age, but it is constant, it's not changing. There is a difference in the male and female in the this one, hypertension, atherosclerosis. RCN is only present in the females. No male representation here in the RCN. Crescentic GN is again have a variation of age. So if we look further into the with year-wise change in the pattern of glomerular disease, so lupus nephritis is relatively constant. There is no change in the age or presentation with years passing. Amyloidosis is little bit constant. There is no big change, and there is also diabetic nephropathy and hypertension is same. RCN is again on the young population. That is not big change in with years. One slight change in the crescentic GN, slight increase in the age where the age passes. So this is reports are there that show that the crescentic GNs or membrano proliferative GNs increase with after COVID infection or even vaccinations. So that might be a reflection of post-COVID time. So if we look the glomerular disease in elderly patient again there is this is more than 60%, more than 60 years, and we found that FSGS and membranous is the most common primary disease in elderly patients, and this is crescentic GN is most common in secondary glomerular disease. So elderly patients have most common FSGS, membranous, and crescentic GN in our database. And if we look overall, worldwide, again, membranous, crescentic GN, FSGS, these are the again most common representations of glomerular disease in elderly. So we are, our data are also representing the same as from other centers. Now look, what are the outcome of this primary disease? If we look MCD has a good response. It is a complete response of around 88%. Partial response is there. Most of the patient respond, either complete response mostly or partial response. In FSGS, there is a slight decrease in the complete response, and partial response is again is there. Overall cumulative response is around 63 or 70%. That is again representing the data is around FSGS showing the response rate of around 63, and MCD showing 75. That is our patients are showing better response. If you look for IgA nephropathy, there are it is difficult to define response in IgA nephropathy. But what are the ways if the patient present with a proteinuria? So there is a complete response in proteinuria in around 5% of patient. Partial response is again 5%. On patient who underwent renal transplantation, this is around 15% of patient underwent renal transplantation, and these patients are on end-stage renal disease. And patient on dialysis around 40%, and mortality is around 5%, and significant around 15% of patient lost to follow. So if you look for from the data, there is around 5% death is reported, and ESRD is 20%. In our patients are slightly on higher risk for end-stage renal disease, so that need to be looked. This again MPGN. Here again the MPGN response is not good. Complete response is found only 10%. Partial response is around 30%. No response around 20%, on dialysis around 10%, and a patient around 50% expired, and lost to follow-up around 10%. So again, the response of MPGN is not good compared to the MCD and FSGS. So what are the treatment options we have, and what are the challenges? If we look overall glomerular disease data from UK and US, this is the disease present in the young. In 18 to 20, this is around 38% percent of patients is in this age group. And as the ages passes, its prevalence decreases. And as the ages passes, the prevalence of diabetes increases. So this glomerular disease is the disease of young, that is affecting young life and the earning member of household. So treatment option what we have? We have very non-specific treatment because we need to treat this inflammation by either glucocorticoids or antimetabolites in the form of azathioprine or cyclophosphamide or mycophenolate. These are very non-specific immunosuppression. We try to suppress the immunity and decrease the inflammation so that glomeruli can regain its function and get to the normal. Other options are there that we see in the form of biologics. These are very specific therapies, and in our case, we are using rituximab most frequently, and that is recommended by FDA. And next is eculizumab. These are the new biologics coming into the treatment of glomerular disease, and especially in C3GN and MPGN, we are using eculizumab. But this is not commonly used here. Rituximab we commonly using in our patients. If we look for the rituximab data, most of the patient in which we use rituximab is membranous nephropathy, PGN-MID, MPGN, ankylosing vasculitis, and ABMR. All these are indication of rituximab use commonly in the nephrology practice. So what are the challenges in resource limiting setting, like in developing countries? This is a very good study that try to find what the challenges we are facing when we are dealing glomerular disease patients. Electron microscopy is a very important tool to assess and classify the glomerular disease further, and it was found that hardly 10% of glomerular disease biopsies are screened under electron microscopy. So there is a very limitation of electron microscopy in various countries, especially Asian and Africans. Again, IF is also limited, but electron microscopy is required to delineate or to get the detail of glomerular disease. If you look how easily, this is the red bar is showing how difficult to get this testing, like autoimmune markers, and these are drugs. And blue showing how easily the drug is available. So if we look the autoimmune marker from ANA, ANCA, and other anti-PLAR and the complement, there is a difficulty in getting these markers done. So there is a limitations of these auto antibodies availability in most of the countries. Here the glucocorticoids are easily available, but there is a difficulty in getting the biologics, especially rituximab, all these medication. So availability of these diagnostic tests in the form of electron microscopy and autoimmune markers like anti-PLAR and complements have a limitations, and rituximab or biologics are not freely available in especially resource limiting setting. So what are the advances there in the glomerular disease in making diagnosis? As we already highlighted, electron microscopy is very important, and this is, we often screen the patients of early kidney biopsy from light microscopy to the IF immunofluorescence, and electron microscopy is an important tool to assess the glomerular disease. And this study compared how the electron microscopy is affecting the overall diagnosis. So it is very critical in around 10 to the range is from 6 to 70%, but if we take the mean, it is around 10 to 20% of patients need electron microscopy to give appropriate diagnosis of glomerular disease. So this is a video that is from Yale University when they got this one electron microscopy in their lab, and they found that this is very short video. We can go through it. And
did you join the company just 5 months back?
Yeah, I did, but why are you asking me?
How did you get promoted so fast?
Hi, my name is Gilbert Muckle. I'm professor of pathology in the Department of pathology at Yale, and I want to show you our new electron microscope that we recently acquired. We use electron microscopy to visualize ultrastructure in kidney biopsies. And how this machine works, it shoots electrons through the tissue, and you can therefore see what is inside the cell, what the mitochondria and other organelles are doing, and you can identify pathological changes such as immune complex deposition. Our manager, Sarah Pollack, spent a lot of time testing different electron microscopes, and she decided with this one because it was just the microscope that had the best ergonomic facilitation and was also perfect for our need in diagnostic renal pathology. Without electron microscopy, we would probably get 10 to 20% of the kidney biopsies not diagnosed accurately, but with electron microscopy, we practice close to 100% accuracy. So a very important tool for our clinical renal pathology practice.
So this was a short video, the importance of electron microscopy here. Now we look what are the next in the glomerular disease. Another is a liquid kidney biopsy that is coming up, and as you know, as days passes, we are more in the proteomics, more towards the precision medicine, and these are very important tool for future in making the diagnosis and treatment monitoring. If you look all these upcoming proteomics, there is a cell that is secreting a lot of proteins in the form of exomes, and these exomes contain microRNA, protein, hormones, and these are analyzed and with the different techniques, either in the form of genomics, proteomics, or metabolomics, and we find the pattern of disease, pattern of proteins in particular disease, and try to look the diagnostic capabilities of these different facilities we have. This is at the infancy, but in near future, these are going to capture the most of the areas. So again, there is these proteomics. We can have a different protein signatures, and these protein signatures are used in follow-up and both making the diagnosis and treatment monitoring. And there's a lot of advantage of these proteomics compared to the kidney biopsy. Kidney biopsies are invasive, it is easily available, desampling can be possible and can be used in clinics, easily available, and these are a lot of benefit compared to the invasive kidney biopsy. So these are the tests that need to be looked in the future for making diagnosis in glomerular disease. What is the role? Here it help in early diagnosing, prediction of the disease progression is there. We can monitor drug response, and evaluation of drug target and drug development is in that area. It's also useful, and treatment monitoring is helpful with these techniques. Now we go further. What are the other way we can monitor or make the diagnosis these glomerular disease early? There are various markers are there. There are blood markers like we already using in many of the disease. Galactose deficients, membranous, we are using PLAR antibodies, SUPAR and FSGS, and there are other complement markers are there in MPGN. The histological grading are there in different primary glomerular disease, that is we are using. Urine biomarkers are in the pipeline, and there are multiple drug studies are there, and we are in the progress to refine this significance of these markers. There are genome-wide associations are there with many of these primary disease, especially IgA nephropathy, and this again genetic associations are there. So this is in the pipeline, and we try to refine our understanding regarding these particular disease which are commonly affecting our young patient. Now this is the next stage is artificial intelligence. This is very in near future likely to capture our or be a part of the many part of our diagnostic treatment and follow-up patients. And the most common area where we likely to find in future artificial intelligence is in the diagnosis of AKI, CKD, diagnosis and follow-up, dialysis and renal transplantation. But here we are focusing on the nephropathies where the artificial intelligence can use for the analysis of image. Because most of the histology is on the basis of image that we get, and we try to find what are the pathologies going on. And if we train these machines with the available data, with gradual refinement of this understanding, these artificial intelligence can be used in analysis or diagnostic purpose of glomerular disease. There is a evidence are there, especially in IgA nephropathy. They used histological data in prediction of overall survival in IgA nephropathy, and they use this algorithm. On that algorithm, they assess overall power of these tools in prediction of survival in IgA nephropathy, and they found that it is a very good result and very good sensitivity and specificity. The area of undercurve is also very good when we are using this algorithm-based learning in that area, especially diagnosing IgA nephropathy. So this is a new upcoming future where we can use these techniques for making the diagnosis of glomerular disease. What are the therapies? What are the advances in treatment part? Because most of these glomerular disease are either caused by the infection, autoimmunity, or there is a monoclonal gammopathies or monoclonal antibodies are there that is causing the damage. So there is a new classification put forward on the basis of pathogenesis. What we find now is on the basis of look, what we see in the microscope. But this is a new classification might come in the future that is specially focused on the causation of glomerular disease. So either it is due to infection, autoimmunity, antibodies, because especially in the renal transplantations, autoinflammations by some person or some group of people are more predisposed for certain disease like genetic association need to look, and monoclonal antibodies that are we often find in various plasma cell disorders. So again, there is a further refinement. If infection, there is no need to give additional immunosuppression. We treat the infection and follow the patient. Autoimmunity, we try to find the look for the antibodies and try to look the clones which are secreting these autoantibodies and try to target these. And alloimmunity, try to find the here we can use immunosuppressions, because especially in renal transplantation. Autoinflammation, especially genetic pathways are there which predispose this patient for the causation of the disease, so we can block these pathways. And monoclonal gammopathy, again we can hit the clones. So these are different grading on the basis of activity and chronicity. So now it comes how to target this plasma cell, because most of the glomerular disease are caused by some form of antibodies, and these antibodies are there in our body, but which cell, what is the source of these antibodies, we don't know. There are a lot of things we tried, from flow cytometry to bone marrow, but we're not able to hit these plasma cells, these abnormal clones. And there are many, even more than 2 trillion lymphocytes are there in lymphoid tissues, in the bone marrow. How to hit these plasma cells? It is a most difficult task. And what we have, we blindly use immunosuppression. We give glucocorticoid, hit all the cell available. They blindly hitting all the cells, and whichever coming in front, they kill all the cells. But these cells are also useful of our body. So how to target these cells? This is a very important challenge at present. And if we look, if we able to detect these, there are, in lupus nephritis, there are certain antibodies which are secreted by these clones, abnormal clones. And this ANCA-associated vasculitis, there is antibodies that directly associate with the causation of the disease. There is another anti-GBM disease, membranous nephropathy, IgA nephropathy, uh, even in renal transplantations. So these antibodies are continuously secreted from the plasma cell that is sitting inside our body. Where it is, we don't know. So these are the available therapies which we can hit these plasma cells. But what are the limitations of these available therapies that need to look? So whenever there is these B cells are activated, these are converted into the plasmablast, and these plasmablasts proliferate and secrete lot of antibodies, and they finally converted lodge into the bone marrow or in inflamed tissue, and where it become a long-lived plasma cells, and continuously they are secreting antibodies from there. So these antibodies are actually causing damage in our glomerulus. What are the available therapies there? There are proteasome inhibitors we have, and these can target this one bone marrow and the inflamed tissue. And ATG is again blindly select all the memory cells. But memory cells also are good because we got vaccination. Vaccination exposure is good to protect us from the infections. But these available therapy eradicate all the plasma, long-lived plasma cells. This means these patients again on high risk for infection if we use these aggressive therapies. So there need to be look how to balance between these two. This is a very interesting things that coming up, and this is here. There's a lot of biologics are used to target the plasma cells with the inhibiting its receptors. There is a proteasome inhibitor, anti-CD38. There is a lot of biologics are coming up in the market. But good thing is that this is a here very interesting thing is here. They use especially how to target the abnormal plasma cell. Here it is very important. They use antibody against CD138. And CD138 is a marker of long-lived plasma cells. And over that, they target autoantigen. This autoantigen is target on anti-CD38, and it lodges on all long-lived plasma cells. And if this cell is producing that autoantibody, these autoantibodies will find this autoantigen and this bind on this cell, this abnormal cell. And this abnormal, when there is an antibody and antigen binding is there, that will activate the complement. And only those cells that are actually causing the problem, they got lysed. This is like atom bomb sitting on the particular cell. So especially that particular cell that is actually secreting these antibodies are especially hit. And rest of the plasma cells that are good, that have our exposure of vaccination, lot of vaccination we have a past exposure of infection that prevent us from increased risk of this infectious complication. These plasma cells are safe because these antibodies that are secreted that are not specific to this autoantigen. So this here the complement will not activate, but complement will activate only those when the antibodies and antigen find it, and this especially abnormal plasma cell hit it out. And this is a very specific, and this concept is given by George J.K. Kohler. He is a German biologist, and he received Nobel Prize for that also. Not for specific this concept, he given this concept, but for other work he did in the immunology part. So what are the facilities which likely to boon the research in glomerular disease? Like if we have a continuous facility of immunofluorescence with subclassification of IG1, IG2, IG3, IG4, immunohistochemistry markers of rare renal disease that are very useful, electron microscopy again that we are highlighted in our presentation, and mass spectrometry that help in making liquid kidney biopsy possible. These are the things that require in a research institute. Now, this is the overall data we have in our centers. This is the things we are doing here, and Subsequently, there are other centers are there in our state. This is the Bikaner, where the kidney biopsies are done in the public tertiary care center. Jaipur is again an important center where the kidney biopsies are routinely done. Kota is there, and Udaipur. So there are other 4 centers are there where kidney biopsy in the public centers are done. So we try to make a coordination or communication with these people. And here in Udaipur, Dr. Mukesh Barjatia is there. He's ready to come and share data with us. And we found that the pattern of glomerular disease is as that is represented in our database. So in Udaipur also, FHGS is the most common cause of primary glomerular disease, and lupus nephritis is again the most common cause of secondary glomerular disease. So this is the data from the Udaipur that we analyze. We talk to the peoples in Jaipur, and we find that this is the most of the biopsies sent to the outside in Lalpath, and we try to make a contact, and they are ready to share their data. And we are in process to coordinate with Kota and Bikaner. So we have a complete representation of glomerular data of our state. So what we need to improve ourselves more, we have to be better organize ourselves for data collection, because data collection is very important to evolve ourselves. We need more follow-up data, because whatever we are getting is on the patient spots data that the patient is coming in contact with the health institute, but we need more follow-up data. We need to establish effective specialty clinics that regularly collect these data. Coordination, collaboration with other departments, both inter and interinstitutional, involve more in the molecular and pathophysiological studies to get the knowledge in the depth, and keep learning more, improve ourselves, and establish our department as a center of research and academics in the state. Thank you.